Hello, everybody. Welcome to the WFUMB webinar on carotid arteries. The WFUMB webinars are organized by the Education Committee of the World Federation for Ultrasound in Medicine and Biology. Please allow me to introduce myself. I'm Dr. Leandro Fernandez from Venezuela. I am Director of the Laboratory of Advanced Sonography at Instituto Médico La Floresta Medical Institute in Caracas, capital city. I am WFUMB Regional Director for Centers of Education in Latin America. And today I have a very special invited speaker, who is Dr. Michael Lilly from USA. He is Professor of Vascular Surgery at the Maryland University. In this coming time, we will discuss on IMT stenosis and cardiovascular disease impact on sonographic findings. Let's begin. IMT, an internal carotid stenosis ultrasound assessment. This is the outline of the presentation. I will mention some indications. I will just say a couple of words regarding anatomy. I have to make some comments related to IMT. Then we will see the technique, how to identify the plaques, and of course, how can we do the stenosis quantification. Applications. Well, we have to look for atherosclerotic lesions. And the clinical manifestation of these lesions are the transitory ischemic attack, the established stroke, and the amaurosis fugax. There are non-atherosclerotic lesions that can be seen by using color Doppler. Kinking, arteritis, aneurysms, and fistula, and some other, as you can see here on the slide. Anatomy, just a reminder, the common carotid artery, the right one, rise up from the brachiocephalic trunk and then divides in internal and external carotid artery. The left common carotid artery rise up directly from the aortic arc. The advantage to ultrasound compared with MRI and CT scan is that, of course, we can see the walls, we can see the flow, but with Doppler, we can see the hemodynamic pattern. We can estimate and we can evaluate that in a quantitative way. In this diagram here, I want to show you where the bifurcation is located and where is located the bulb. Normally, the bulb is the proximal third of the internal carotid artery. And here we have now a real color Doppler image. And with the arrows, we will demonstrate where these structures are located. And for this lecture, we will be focused on the internal carotid artery. Study protocol. Well, we start the study in B mode. You can start in transversal or you can start in longitudinal. This is up to you. But you have to do both approaches, longitudinal and transversal. Please activate the tools that you probably have in your systems. Real-time compound ultrasound and speckle reduction imaging are very useful tools in order to obtain a high quality kind of image. Then we go to Doppler. We will use the color Doppler, the power Doppler, which is very important. You can obtain a very clear depiction of the flow and of the vessel with power Doppler. And then we go to the spectral analysis for the hemodynamic calculations. I want to mention some words related to the IMT. IMT and the American College of Cardiology and the American Heart Association. This work group recommended against measurement the IMT in clinical practice for risk assessment based on concerns regarding measurements, quality standards, method standardization, and level of evidence of the reviewed articles. They reviewed 3 very important articles. So they found Different segments were measured. They found different kind of measures, maximum IMT, mean MIT. So it is necessary to standardize the protocol to obtain valid results. That's the reason, because in 2013, they did this recommendation. But in somehow this is it's kind of controversial, because although the cardiologists, they say it is not necessary, don't do it, many other physicians from other specialties request the IMT value. For example, in neurology, in rheumatology, not in cardiology. And you can see here recent papers, 2019, 2020, where rheumatology specialists, for example, evaluate the inflammation state of the patient with the IMT, or neurologists and the relation of the IMT and subclinical atherosclerosis of these patients. So the international community has a big interest to resolve this issue. And we have papers. For example, this one, the MESA study conducted by Dr. Pollack and published in January 2017. In this paper, they considered age, sex. They include ethnical groups, non-Hispanic, whites, blacks, Afro-descendants, Hispanics, and Chinese participants. So they propose an IMT score compared with coronary artery calcium by CT, or with the Framingham risk factors. They are also proposing different types of measurements, and the places we have to standardize. Again, I say that the places where the carotid will be measured. So it seems at this moment that the IMT is more an epidemiological tool in order to try to identify groups of risk. But I could say that we have to wait, because further pertinent studies not examined in the guidelines were published, and their positive results might warrant revision of this recommendation of the American Heart and the American College Association. Okay, let's go back to the study protocol. We start in this case with longitudinal B mode image, where we can see here and an internal MIT, normal MIT, IMT. I'm sorry. A normal IMT with no plaques in B mode. And that's the reason, because we also have to activate the color Doppler in order to be sure that we have a complete feeling of the vessels with no plaques, hypoechogenic plaques that probably could be there. In longitudinal and here in transversal, we are seeing very easily that we have a big plaque here. Is a mixed plaque. Let's see it again. Now this is the distal segment of the carotid, common carotid artery. Now this is the bifurcation, and look here, calcification, acoustic shadows, and then the plaque enters to the external carotid artery and to the internal carotid artery. In real time, it's just a few seconds. That allows, and this image allows us to see a complete picture, a comprehensive picture, really. Then we move to the internal carotid artery, the ICA bulk region. Normally or frequently is the first or the proximal third of the internal carotid artery. And it has a very particular flow pattern. The flow here is helical, like a whirlpool. And when we apply color Doppler to this helical flow, we will find opposite codification of the color. So one red portion and one blue corresponding to this whirlpool area. Could be small one, could be medium one, could be a big one. But the most important thing is not the size, but you have to see it. Because if you don't see the helical flow, In many times, it is because a plaque is disturbing the normal flow pattern. And now we have here the internal carotid artery Doppler. We can see here a wave that shows us low resistance. I mean low resistance when the value of the resistance index is less than 0.7. It's a monophasic wave. And why we use the expression monophasic? Because we are using the baseline as a limit. We have an upper part and a lower part. And all this wave pattern is located in one side of the spectrum. That's the reason because we say monophasic. Some authors call that biphasic because it has a systolic and diastolic phases. This is correct, but if we want to express or use an Doppler expression, I think that monophasic is a proper expression. The window, the Doppler window is empty. If you see it with echoes, it means that this patient has turbulence. And the velocity is less than 100 centimeters per second. How to identify the plaques? We have soft plaques, fibrotic plaques, calcified plaques, and complicated plaques, and mixed plaques, and mixed plaques also. The soft plaque has high potential of brain embolism. The fibrotic, medium potential, the calcified, low potential, but the complicated plaque has a very high potential of brain embolism. We can recognize the type of plaque. For example, this is a soft plaque, very hypoechogenic. The soft plaque is hypoechogenic, and most of the plaques are located at the bifurcation, 80% of them. At the origin of the internal, and then from the bifurcation, they enters to the origin of internal carotid artery, ICA, or to the initial segment of the external carotid artery, ECA. Now we have a calcified plaque. This is hyperechogenic area with acoustic shadow. So this is how we can see the calcified plaque. And this is a complex plaque where we can see fibrolipidic areas, fibrosis here, but we see anechoic areas inside the plaque. Those anechoic images normally corresponds to hemorrhage, or correspond to necrosis inside the plaque. Very high potential. Why do we need to calculate the stenosis severity? Well, embolization risk is associated to the stenosis grade. An embolization risk is related to plaque friability. Turbulent flow and high velocity jets increase the friability. Hemorrhagic plaques also, and as well, irregular surface of the plaque. How can we calculate the stenosis quantification? Well, there are two methods with different, or two different ways to do that with different methods. We have the North American study and we have the European study. Both of them were published in 1991. The North American method recommends to make the measurement at the end of the plaque. We need to obtain this diameter in the normal or in the normal portion of the vessel, and we will compare this diameter with the residual lumen. And here we have the European. The European recommends to make the measurements in the plaque place. We have to include the diameter of the plaque. So we will compare this diameter here with this residual lumen diameter. And then we apply the same formula, but we don't do it, the system do it. Those are nice, those are good, but the problem is that they are not equivalent. The NASET system tends to underestimate the stenosis, and the European tend to overestimate the stenosis. And for example, you can see here that 40% of the NASET correspond with 70% of the European. So, and it was an issue because we sonographists and sonographers, we have to make a report with the value, with the recommendation for surgeons or for clinicians in order to decide what kind of treatment they will propose. So let's see an example here. This is an ICA stenosis in a symptomatic patient. Here with color, we can observe where the aliasing is, the more acceleration of the velocity. And here we can see with power Doppler. So which method are we going to use? And for example, with the transversal view, the transversal approach, we can obtain also a value. This also tends to overestimate. So this concern were in all the medical community, sonographist community, and the Society of Radiologists in Ultrasound Consensus Conference was published in 2003. Some years ago, this project was led by Dr. Edward Grant, and in this consensus, they did a relation between the plaque in B mode, the velocity, and a ratio, ICA-CCA ratio. Those are tiny numbers here. Let's move to another slide where we can see the numbers better. So if you have a carotid artery, internal carotid artery, with no plaques, and the velocity is less than 125 centimeters per second, this is normal. If we have a plaque, if you have a plaque, and the velocity is still less than 125 centimeters per second, and the ratio ICA-CCA is less than 2, this is a mild stenosis. You have a plaque, but now the velocity is between 125 to 230, and the ICA-CCA ratio is more than 2, but less than 4. This is a moderate stenosis. Both of them needs medical treatment, usually. This one, both of them. So medical treatment, pills. But if you have a plaque and your velocity is over 230 centimeters per second, and the ICA-CCA ratio is more than 4, so we have now a severe stenosis equal or greater than 70%. We have near occlusion and near to near occlusion. In this case, the velocity frequently has a drop of the value. And 100% total occlusion. No echo signal in B mode or Doppler. There is no lumen that we can see it. All these calculations were done with an angle correction of 60 degrees. So if you are going to use that, you need to adjust your angle in 60 degrees. And let's go back to the same image. Now we are using NASET, the position of the calipers, and the computer says that we have 64% of stenosis. The same image, but now the caliper are Europeans, and here the system says that we have 83%, which is the real stenosis. So we have to go to Doppler to see the hemodynamic pattern, and we can see the velocity is 325 over 230, and the velocity previous to stenosis is 39. If we do the calculation of the ICA-CCA ratio, is 8.3, more than 4. So no doubt this is a severe stenosis, greater or equal to 70%, probably greater than 70%. So regarding the SRU consensus, in 2010, 152 vascular labs respond that they were using the SRU diagnostic criteria, 27% of them in 2010. This organization, the Intersocietal Accreditation Commission, the one that gives vascularization to, give accreditation for the vascular labs, they did a survey. Well, in 2015, they recommended that laboratories without rigorously validated internal criteria use their SRU consensus criteria, because it has a very close match with the angiographic findings. An example, this patient has visited our lab and he has a severe stenosis. Look at the velocity, 350, the plate here, aliasing here. So this patient, this is the angiogram of this patient, where you can see the severe stenosis, and the decision of the surgeons at this moment was to place a stent in order to correct the stenosis. So this is pre-stenting and this is post-stenting. And here the ultrasound of the stents. This is the normal appearance, and the important is the localization, but also the Doppler bifurcation with the first portion of the stent. And see here, please, that the wave is normal and the velocity dropped to 96 centimeters per second, from 350 to 96% as a response to the stent. Is carotid Doppler good? Well, according to evidence-based medicine, is a level of evidence C, and it is a class 1 when we have suspicion or known disease of carotid disease. I mean, class 2A when the patient has a bruit, or in the case of follow-up. Oh, I'm sorry. In a case of follow-up. And it's a class 2B when the patient has coronary heart disease or peripheral artery disease or abdominal aortic aneurysm. But it is a class C. It means not recommended in a random patient without personal or family background. Yes, this is very good, but we have some technical problems that we have to have in mind, and we have to resolve it or solve it. The Doppler angle, the sample volume box, the color Doppler, sampling window, color velocity scale, and color gain. If you adjust all these parameters in the proper way, so we have a sensitivity of 90%, a specificity of 89%, and combining this ultrasound duplex criteria, duplex ultrasound, color, etc., this combination allows a reliable grading of carotid stenosis as a basis for decision. But the method has limitation: obesity, short because of the short neck in these cases, also high bifurcation, tortuous vessels, hostile necks, for example, in case of radiotherapy, surgery, hematoma, central catheter, severe cervical osteoarthritis, and calcified plaques with large shadows. So I can say finally that Doppler, carotid Doppler, is the first choice imaging study and the only one in most of the times for diagnostic and grade of the stenosis estimations. Well, my friends, thank you for watching, and I think that we have time for a couple of questions, if we have some, and if we haven't, we can move on to the lecture of Dr. Lilly.